Well, I was trained originally as a psychologist at the University of Chicago, got my doctorate from the University of Chicago. And I was then trained to be a standard clinical psychologist, which meant that I was focusing on treating people who had mental illnesses, and I was trained in various models of psychological treatment, psychotherapy, cognitive behavioral therapy. And it became clear to me as I practiced that, one, there were patients who benefited only when they received medications, mental health medications, and that I was curious about how those medications worked, but I was also more concerned about how long it took oftentimes for patients to get in to see a psychiatrist who could provide those medications. And so because I was concerned about my patients and recognizing some of them would benefit more, I decided to undergo the American Psychological Association's recommended training to become a prescribing psychologist. And so at age 53, I went back to get a postdoctoral master's in clinical psychopharmacology. I would say our work, what we do, how we practice, and the impact of that would persuade anyone here that what we're doing is healthy for patients and constructive and making a real contribution. And I think you discover it because we're now sort of, it seems normal to the physicians here that there be a psychologist that prescribes, including to psychiatrists here, a couple of whom have actually hired prescribing psychologists to work in their practices and provide supervision and education and training, that it's sort of it's now normalized, so we are an expected part of the population. With regard to how we relate to psychiatry, I don't want to offend our psychiatrist colleagues, but I'll say that I think that the best psychologists, prescribers, are reading the same literature and trying to practice with the same standard as the best of the psychiatrists. So if you want to know what we need as prescribing psychologists to learn to pass the tests that you have to pass to become a prescribing psychologist, it's study the review guides for the psychiatry and neurology boards. It's the same material. The ethics are the same. The quality of care standards are the same. So we are much more similar to psychiatry than people would realize. The difference is psychiatry, they learn physical medicine first, and then they learn psychology in their residency. Psychologists learn psychology first, then they learn physical medicine in their postdoctoral training. And so it's similar content, it's a different order. Now there's a different depth to the physical medicine that psychiatrists are learning. So they have the training they're getting going through medical school is more in depth in terms of general physical medicine, because they're being trained for the basics of what you'd need to do surgery, to do OB-GYN, to do internal medicine. And then they specialize in psychology and learn psychology in their psychiatric residency. When a patient is referred to me there and they come to see me, I take a complete health history, including finding out what medications they're taking. I find out who their primary care physician is, and I work with the patient to determine what their diagnosis is. And if I'm going to recommend medications, I'll discuss that with the patient, get informed consent, but then I'll say, well, before I'm going to prescribe this medication for you, I want to talk to your primary care doctor. So I call the primary care doctor on the phone, identify who I am, and say, the patient's come to me, here's the condition that they want me to treat. I'm considering this medication. Do you think that is medically appropriate, or would that compromise their health? So I'm getting sign off by the patient's primary care doctor. If they don't have a primary care doctor, I say to them, well, let's get you to a primary care doctor. I refer them to a PCP to get a physical, to get labs, so there are labs on the patient. So then the primary care doctor can advise me as to the safety for the patient. So that's not a really difficult nut to crack to manage that if you're in private practice. Well, if you look at where we are all over the state and in rural areas. And if you look at our panel of patients here at the Family Medicine Center, although this is Las Cruces, New Mexico, half of our patients are rural, and they come in here from rural areas in New Mexico for care. And so the law has actually enabled there to be more services available to underserved populations and rural populations. In New Mexico, if you look at all the categories where the academic institutions are training healthcare providers of various kinds, nurses, psychologists, social workers, physicians, the only category where more people have come to New Mexico than left is prescribing psychologists. So New Mexico's drawn, it's the one category where New Mexico's not training people who then leave in more than half the cases. So in fact, it has drawn people from elsewhere. And I think I've mentioned that I commute out from Chicago. I have a practice in Chicago, and so I'm here every other week. And I have a practice in Illinois, and there are other Illinois psychologists who also have come out here and worked. And we have prescribing psychology trainees from elsewhere who've trained here and are now moving here and staying. So it has actually drawn people to a much needed area in a much needed category of healthcare, which is behavioral healthcare. I'm thinking of one who I'm managing medication for who has a bipolar disorder. And this patient came first, extremely manic, had gone off the mood stabilizer medication, didn't want to be on actually a potpourri of medication, which seemed to the patient like it was too many medications. It's called polypharmacy. Had heard about that, decided to go off the medications. And this person was genuinely miserable, unable to sleep, unable to rest, had this experienced kind of agitated fatigue, and her health was crashing basically, because that kind of a condition has a negative impact on a person's physical health. And starting a mood stabilizer with that patient, and then having that patient benefit, and then working with that patient in counseling, in long-term counseling, to help her regulate her lifestyle so that she had a regularized sleep-wake lifestyle, learning to cope with stressors in a way that she didn't get so agitated by them. So combining psychotherapy and cognitive behavioral therapy in a longer-term relationship, and monitoring the patient over time on the mood stabilizer, making sure, doing labs at appropriate times to make sure that the patient's health status would continue to stay improved. And it is an absolute night and day difference in the way that patient is functioning, and continues to function now as a parent, a very constructive parent and member of a family and contributor to the community. And you see that kind of just sterling examples of really needing to utilize both, combine them, have a longer term relationship with the patient, that's the most effective thing you can do. And it's very satisfying to be able to provide both, to coordinate both, and to be able to follow up with the patient.